My colleague has given me the task of talking about one-stage versus two-stage surgery in infected non-unions. And as I was preparing for this, it became increasingly apparent that this is going to be a bit of an opinion piece because actually the evidence for this is really poor. So I'm going to talk about my thoughts on it and what I base that on, and then I'm happy for the rest of the faculty to weigh in as we get to any questions. So this is a slightly less dramatic case than some of the previous ones, but serves to illustrate a point. This is a 30-year-old gentleman. About 3 months before this X-ray, he'd had a high-energy road traffic collision on his motorbike. He had multiple fractures, including this femoral fracture. It was nailed by one of my colleagues. He was the first to admit he had a bad day at the office. This is not how he had planned the surgery to end up. And unfortunately, 3 months down the line, he came to my clinic with a discharging sinus at this level through the wound that had to be used to open reduce this fracture because he couldn't pass the nail closed. So bad day all round. And this is the sort of thing we see in trauma meetings quite a lot, and that your standard trauma pod who isn't in this room tries to shy away from and shunt towards somebody else's operating list. Because there's lots of things to deal with here. We've got a big bone defect. We've got loose pieces of bone that are several postcodes away from where they should be. Probably have significant soft tissue stripping from the surgery and from the original injury. And now we've got pus coming out here, we've got pus coming out the top of the nail, there's infection all the way up and down. We know there's going to be biofilm on the implant at this point, and probably on any dead bits of bone as well. And so it feels like there's too many things to really think about to deal all in one go. We want to get rid of this horrible thing. Everyone has their favorite picture of a biofilm. So this is my one. We've seen 3 or 4 others already. We know that bugs like to stick to the surface of the bacteria, to the surface of your implants. This is what they do when they come into contact with them, if they at all can. It starts to develop very early on, and by the time it's mature, it means that our immune system and our antibiotics really have a tough time actually getting in and removing the bacteria. So the only way to get rid of it ultimately is to physically remove it, usually with the removal of the implants and devitalized bone. But if we do that and we just go in and take out all these loose bits and we take out the nail, then we're back to where we started from with a broken femur. A patient who can't get out of bed is in pain. He'll have inflammation. He'll have hematoma at this level. And this is not the environment that is conducive to resolving an infection. It's also not an environment that's conducive to treating the non-union as well. So it's bad from both accounts. The other issue that Alex touched on is when you're treating infection in a bone, you don't just end up removing the obvious loose bits of bone. You do have to debride often more than you think. So this is a typical osteomyelitis case of mine. This was a previously plated tibia. The plate came out for infection many years ago, but he still had a discharging sinus. When you get down to the bone, there's a cloaca with a sequestrum, a beautiful piece of dead bone in the middle of it, complete with 2 unhealed screw holes from 20-odd years ago. That sequestrum is going to go in the bin immediately, and then we'll start enlarging the cloaca to get a window into the medullary cavity to deal with the infection in there. As we do that, we're taking away more bone, and as we're sequentially debriding it, we find more white sclerotic areas of cortex that aren't alive, are again probably covered in biofilm, and my preference certainly is to remove them to give us the best chance of clearing infection. That process continues until we see nicely into the medullary cavity itself, and then in this case we find further intramedullary sequestrum that need to come out as well. So we get to a situation eventually where everything looks like it's alive, everything looks like it's bleeding, and at some point you have to call it a day and say, I've debrided enough. And decision as to when that is probably the most difficult thing in osteomyelitis surgery. But as you can see, we've gone from quite a small hole to quite a big hole in the bone. And when we're dealing with an infected non-union, that seems counterintuitive. We're digging ourselves a deeper and deeper hole here to have to deal with. The other issue is that when I've done all that and I've taken all that bone away, Who here thinks that in this surgical wound there'll still be some dead bits of bone? So, some bacteria in the surgical field? Some fragments of biofilm? Thank you. Yes, you've got great faith in me, obviously. All of them are always present in every one of these I do. I don't consider myself a perfect surgeon. I'd advise nobody else does when you're doing this sort of surgery. It is impossible to physically remove every last bug. And so with that in mind, it feels very uncomfortable to then say, well, I'm going to put more metal straight back in and I'm going to put bone graft straight back in, because isn't that just going to get infected like the last lot did? Because of this, I think the traditional thinking has been to treat infected non-unions as a two-stage operation. So effectively separating the treatment of the infection from the treatment of the non-union. So you're aiming, in an ideal world, to go from an infected non-union to an aseptic non-union, and then ultimately from there, via another operation, to a united bone. The other requirement for doing two-stage surgery is partly related to antibiotic delivery, because in the bad old days, our main delivery mechanism for local antibiotics was PMMA cement. So we would make this into nice little beads on a wire, pack that into the defect, and then have to go in and remove those because it's not bioabsorbable. It'll stay there forever with more biofilm sticking to it if you leave it there. Having said all of that, if you think about the surgical principles of how you treat osteomyelitis, I mean, these are my sort of big hitters. So I want a patient whose medical comorbidities are as optimized as possibly can be. I want to excise all the dead and infected tissues. I want to take my micro samples. 5 and 2, I think, is an absolutely appropriate number. I want to manage the dead space so there's not a big hematoma where bugs can get back in and use that as a culture medium. We absolutely have to stabilize the bone. And then with my plastic surgery colleagues, we want good soft tissue coverage. If I do a similar thing for my principles of non-union, there are some parallels, really. I still want an optimized patient. I still want a healthy patient whose diabetes isn't wildly out of control, whose other comorbidities are being managed. As we've heard earlier today, we want to optimize the biology at the non-union site. We want living bone, living cells that are actually doing something there to generate healing. I still believe in sampling for microbiology, even if we don't think it's an infected non-union. A surprising number of supposedly aseptic non-unions do come back with positive cultures. If you do have a bone defect, we might be thinking about putting some sort of osteoconductive matrix in there. And again, we've heard today a lot about optimizing the stability at the fracture site to encourage the healing. So putting them side by side, actually there is a lot of parallels between the two surgeries that we're doing. So why not do it all in one go? There's not, as I said, a lot of brilliant evidence for this in the trauma literature, as far as I'm concerned. There is a lot in the arthroplasty literature, and I have to tip my hat to our arthroplasty colleagues, much as it pains me to do so. They've been treating infection in the presence of metalwork for decades now, and DARE procedures, so debridement and implant retention, is a well-recognized technique for early PJI. It does work. It can eradicate infection. You can get long-term cure, in inverted commas, though I hesitate to use that word with any orthopedic-related infection. And we're getting more and more data now that this works in fracture-related infections as well. We're getting bigger case series that show pretty reasonable, reasonably low recurrence rates with DARE in early FRI. There certainly is a time relation to your success. The earlier you get it, the better your chances are. And almost certainly that relates to the maturity of the biofilm. And as you get beyond 10 weeks, it's harder and harder to eradicate it without physically removing the metalwork. The situation we're really talking about today is that latter stage where you have an established non-union that's also infected, I suppose. So you're going to be beyond this point. So again, this is stolen from Pro Implant Foundation, but it's a PJI algorithm. We've gone past the acute phase, so that now this is, in our case, a chronic infected non-union rather than a chronic PJI. And that's when they start thinking about metalwork exchange and whether they do it all in one go or in multiple stages. There's an awful lot of work that's been done on this in the last couple of decades. Broadly speaking, I think the feeling in the arthroplasty world is that if it's a fairly easy to treat microorganism that you have good antibiotic options for, if you have a good host, a good patient who's has relatively controlled comorbidities, and you have reasonable bone stock and reasonable soft tissue coverage, then actually going for a one-stage exchange seems like a reasonable thing to do. As soon as you start getting, you're not ticking those boxes and you have more complicated patients or more complicated bugs, then dividing the surgery seems to logically make more sense. There's lots of evidence that one stage works in PJI. This is a fairly recent RCT, but there's lots of other ones out there. And I mean, this particular one showed the patients recover quicker, there's less surgical morbidity to the patient from a single stage procedure, as evidenced by their improved PROMs at 3 months. But by the time you get to 18 months, things have equalized because as long as their infection hasn't come back, actually, their function is roughly equivalent. The benefit to us is that there's lower cost to the hospital, there's shorter hospitalization, and it means our whole service can run more efficiently. So it's good for the patient, but it's also beneficial to the healthcare system. And that evolution of how we treat PJIs has sort of paralleled the evolution of the treatment of osteomyelitis. So, I mean, these are 2 papers by my recently retired former mentor, Martin McNally from Oxford. One at the start of his career when he was still working in Northern Ireland, where he published on the 2-stage management of chronic osteomyelitis. This was the Belfast technique. Everything was done in 2 stages. There was a thorough debridement with gentamicin beads when they could be bothered, and then they would go back in and bone graft at a later stage. So everyone, as standard, got 2 operations. Contrast that to a much more recent paper that came out at the end of last year, looking at long-term follow-up with single-stage surgery using bioabsorbable antibiotic carriers. They had, with this system, a lower recurrence rate, so 94% infection-free at 6 years, compared to the 2-stage, obviously with that reduction in morbidity to the patients as well. Part of the reason we can get away with this is what we've already touched upon in some of the earlier talks. So we have new toys now. We have these bioabsorbable antibiotic carriers. So we talked about Stimulan. The one used in that paper was Cerament G, which I use quite a lot. It has a calcium sulfate component that is the antibiotic carrier. It releases, if it's the G version, high concentrations of gentamicin over about the first 7 to 14 days. You get a huge concentration of gentamicin at the surgical site without any real systemic side effects to it. So far more than you get from your average PMA block. The concentration is not just 1,000 times or more higher than the MIC of your average bug that we would see in osteomyelitis. It's also often above the biofilm inhibitory concentration. So actually, it probably even has some activity in mature biofilms. And it doesn't matter what shape you use. So you can make this into beads. You can inject a block of the paste to fill a bone defect. Or I often quite like using this to coat implants that I've put in so that there's a layer of Cerament over the surface of the plate, which at least makes me feel good that I'm protecting it from more bugs getting onto it. It also, this particular carrier is about 40% hydroxyapatite, so that component will hang around for longer and in theory will encourage bone remodeling so it can help with your bone defects. I put this slide in and then I realized I haven't actually looked down a microscope in about 20 years. So I'm told that there are lots of nice osteoblasts that are lining up, about to jump into this hydroxyapatite scaffold and remodel it into proper bone. But I have to admit, it's blobs to me. So with all of that, when do I think we can do one-stage surgery for infected non-unions? This is where it becomes a bit more of an opinion piece, because I don't think there's any great evidence out there. What there is lots of small case series, probably with plenty of bias, probably with somewhat incomplete reporting. So when I use it, well, if we're using it in external fixation, if you're using a fine wire external fixator, as in Mr. Harwood's last talk, I think you can use it pretty much in any scenario. I would quite happily use a circular frame as a single stage definitive fixation in any bone I am able to put it on if I think the patient can tolerate it. As you mentioned, the surgical footprint is so small that the amount of metal that's actually within the bone or close to any infected areas is so small. I'm not really concerned about that getting infected. When you're revising with internal fixation, I think you have to think a bit more closely, and that's when, again, I would parallel what's out there in the PJI literature. So ideally a good host, though I've put that in brackets because I find myself, the more I do this, actually stretching this and using it more and more for patients like this one, you know, the little elderly lady with the infected periprosthetic hip fracture that hasn't healed a year down the line. I can't bring myself to do multiple stage surgeries on her. I'm not sure she's going to survive it. So I convinced myself that giving one really good shot, revising it and going with internal fixation is probably overall in her best interests. And I'll discuss that with them and say, look, there's a chance it may come back, but you know, I think it's on balance reasonable to do. You certainly shouldn't be trying to do one stage if you know you've got a multi-resistant bacteria or you have poor soft tissues that you can't make better with plastic surgery. And you do need sufficient bone contact that you're actually going to expect the fracture to heal. I put this slide in purely for Mr. Royston to say, if it's a tibia, just put a frame on it and never do anything else. But he's walked out just before I gave this talk, so I'm very upset. The more tricky thing, or the more fun thing, is when you get to a situation where you have a critical-sized bone defect after your debridement for the infection. So what is a critical-sized bone defect? I mean, definitions vary, but you know, more than half the cortical diameter over greater than a centimetre probably works as a reasonable rule of thumb. And this is where you can go into your bag and you can look at some of the techniques we've heard about a little bit already. So everything from your bone transport to your induced membrane Masquelet technique. Everyone has their favourite. All of them work in certain settings. And again, the literature is full of small case series, each of which says that their way is the best, effectively. It was summarized in a systematic review a few years ago where 50 studies had over 1,500 patients, and they looked at all the different ways people were doing, were managing critical-sized bone defects in infected non-union. Broadly speaking, they were using the techniques we've heard about already. So bone transport, fairly popular. The Masquelet technique, reasonably popular. There was a surprise number that were just putting bone graft in, and some of them in a single stage, which scares me a little bit. Vascularized, free vascularized grafts, if you have the people who can do them, can certainly work very well. The conclusion from this paper was that all of them sort of work most of the time. They couldn't find any significant differences in terms of rates of healing after the primary planned surgeries, rates of healing after any revisions that were required, recurrence rates, maybe slightly higher in the Masquelet group, though it was non-significant, and the bone transport group, probably due to bias in who you're doing that on realistically. And that was sort of in the conclusions of the paper. But everything in terms of time to union, number of revisions, complications, there wasn't a huge amount of difference that they could prove anything statistical with. So I think it's worth having all those in your bag, and it is very much a pick and choose your ideal for the given situation. I'll finish off just by saying I think this is an evolving field. I think that the more I looked into it for this talk, the more I found that there just isn't great evidence for when you can do a one or two stage. I think the improving antibiotic carriers that we have now make our lives a lot easier. They're not a cheat sheet, but it does mean we can stretch the indications probably. There are a lot of analogies to PJI, so I think we do have to keep an eye on their literature. And really, I think the more I do this, the more it becomes evident that the requirements of treating infection and the requirements of treating non-union aren't necessarily pulling in diametrically opposite directions as much as you might instinctively think. That's about it. Any questions?